good morning all, or afternoon, depending on where you are. Thanks for joining me today. We'll get moving, and just wanted to show you quickly the agenda. I'm going to start by just talking about cognitive functioning, and then I'm going to just jump right into delirium, and then dementia, and then depression, give you some information about those and their differential diagnosis. And then we'll talk about the evaluation process and some of the instruments that can be helpful in these types of evaluations. Of course, there are many kinds of evaluations when working with older adults. People don't typically walk in the office and say, hey, could you tell me if I have delirium, dementia, or depression? As a matter of fact, I can pretty much assure you that that never happens. But that is sometimes the question that we as clinicians have, among many others. People come in because they are having changes, or they may be having trouble remembering recent events or conversations, or misplacing objects. They may have difficulty following tasks. They can't, their family may notice that they're having difficulty following the steps of a complex task, or not responding with a plan, to something that they might normally have responded to. And so people come in with both very real concerns and some that are perceived concerns. But sometimes they have these perceived concerns and it's just normal aging. We know that there's some changes that go along with aging. Things like many older adults may need more time with learning and remembering, but learning still occurs. That's normal aging. We may have more difficulty doing more than one task at a time, but can still follow the steps of a complex task when pressed. Word finding can be more difficult in normal aging. Word loss frequently is not a part of normal aging, as you'll see, but word finding can be more difficult, and that still be a part of normal aging. And then we can expect often some slower processing speed and flexibility in just normal aging. But many older adults are affected by delirium, dementia, and or depression. They are all very serious conditions, and they're particularly common in the elderly. They're not part of normal aging. These are the three that are the most prevalent mental disorders in the elderly, and they are different from one another, but it can often be difficult to distinguish between them because their signs and symptoms may be alike. It's also possible for a person to have more than one of these at a time, and their similar symptoms mean that the conditions often go undetected and untreated. Depression is the most commonly missed diagnosis in the elderly. Delirium, when missed, can be fatal, and dementia often has symptoms that can be confused with depression and delirium, as do the others. You see that depression and dementia are frequently seen in the community and in residential care. Delirium is most often seen in acute care hospitals, but it can also be seen in residential care and in the community as well. So changes in cognition frequently go unrecognized in the elderly, both by the person and by their family and friends around them. The family and friends may become irritated with changes or forgetfulness in a person and not really realize that they're indications of cognitive change and potentially big problems. They're frequently undiagnosed and therefore untreated, as I mentioned. Things that you might see are increasing difficulty following television programs, responding to questions, finding things around the house, again, finding the right words, remembering how to do things that a person normally did, like paying bills or handling money. So for a person who did have that as a practice, recognizing people you know, remembering your way home, putting your clothes on in the right order. Sometimes people are aware of the changes, but they're concerned about what the consequences of that might be. They're concerned that maybe, both the cause and the consequences, they may be afraid that they're losing their mind. They may be concerned that people aren't understanding themselves. They may be afraid if they embarrass themselves in the public. They're concerned about what's happening. Cognitively impaired older persons are at increased risk for accidents, delirium, medical non-adherence, and disability. And although their presentations can be similar in many ways, all three are types of cognitive impairment, and the treatments for each are different. It is really important that clinicians learn to identify key risks and signs and symptoms associated with each of these so that appropriate support and treatment and management may be provided. You see that they're not all curable, but there are treatments for all. Some are reversible depending on the disease. Dementia and most delirium are reversible. Symptoms can overlap, as I've mentioned, especially in those involving the cognitive impairments. and then changes in unusual patterns of behavior. So just to set a little bit of structure for those of you who haven't followed the changes in nomenclature over the years, DSM-5 has created the category of neurocognitive disorders, and dementia and amnestic disorder now fall under neurocognitive disorder, or NCD. All neurocognitive disorders at one time were classified as dementia because they involve similar cognitive impairment and decline, and they most often affect the elderly. But although Alzheimer's disease accounts for the majority of cases of neurocognitive disorders, there are several other conditions that can affect memory and thinking and reasoning, and some that can affect the motor system. And they include some other diseases and other conditions that I'll mention, but also TBI is one of them. Dementia typically refers to a degenerative disorder in the elderly, and DSM, when they created this structure, they expanded that category to disorders of younger adults as well, degenerative disorders of younger adults as well, so HIV, traumatic brain injury, again, primarily cognitive disorders, but both those that are acquired and those that represent decline. So the term dementia, though, is of course still used, especially in looking at the potential etiologies or the possible etiologies of the neurocognitive disorder. And so that's the term that I'm going to use for this presentation. Also included in the DSM-5 are examples of symptoms or observations, and also examples of some areas of assessment for each domain for diagnosing neurocognitive disorders. The DSM-4 included memory and aphasia and apraxia and agnosia and executive functioning, and you can see that the 5 has broadened this to the neurocognitive domains of complex attention, executive function, learning and memory, language, perceptual motor, and social cognition. And you'll hear me mention the DSM-5 recommends domain-oriented cognitive assessment, which is what we'll talk about toward the end. So looking at the neurocognitive disorders as they're listed in the DSM, these disorders can be categorized and diagnosed as either major in nature or mild. Most of them, you see delirium stands on its own, but then the rest are either major or mild neurocognitive disorders. And then the etiology, the probable etiology, is what makes up the rest of the title. So major or mild, of course, depending on the severity of the individual symptoms. Again, for some, such as TBI and HIV, younger as well as older people can be affected. Major cognitive disorder is estimated to affect 1 to 2% of people by age 65, and as many as 30% of the population by age 85. But when there's only a slight decline in one or more of these areas of function, the disorder is considered mild. When the decline in one or more of these functions is severe, then it's considered major. So where an individual falls on the spectrum of neurocognitive impairment is often determined by the degree to which the condition affects his or her level of independence. For both mild and major neurocognitive disorders, though, the decline is typically enough to attract the attention of loved ones or healthcare providers, and that's usually what brings them into your office, and then, of course, that can be confirmed through testing. So these are just some additional, not necessarily related to aging, types of neurocognitive disorders. So let's start with delirium. Patients with suspected cognitive impairment should always be screened for both delirium and depression. Delirium itself is primarily a disorder of attention, and it should be considered in patients who have waxing and waning attention or levels of consciousness. It's commonly a side effect of medications. It is, again, often unrecognized by clinicians, especially in the hospital. Delirium is suggested by the presence of cognitive impairment with acute onset, so hours to days, and a fluctuating course, inattention, so a real difficulty maintaining focus, and then disordered thinking or altered level of consciousness. Attention really is that main area of impairment in delirium. The person is less aware of their surroundings, they're easily distractible, they have trouble with concentration and following commands. In a delirium, thinking and perception and memory are also disordered in addition to attention. The sleep-wake cycle may be disturbed. The person is disoriented. They have decreased level of consciousness, increased or decreased psychomotor activity and metabolic activity, and mood changes. And the elderly are at a higher risk for delirium due to several things, including just the aging process, aging-related changes in response to medications, chronic disease, a decreased capacity for homeostatic regulation, a decreased resistance to stress and disease. So again, it's frequently mistaken for depression or dementia, but the features of delirium that differ from dementia are things like the rapid onset, the short duration, mood shifts from lethargy to agitation. But again, patients with dementia are at an increased risk for delirium, so you may see both. Delirium is often linked to medical conditions, a substance intoxication or withdrawal, again, medications, and then many other causes. Sometimes it can resolve completely in hours to days, but there are cases where it can persist for weeks to months. So looking at those, I'm not going to read all these, but these are the DSM-5 diagnostic criteria that correspond with the things that I've just mentioned, the disturbance of consciousness, change in cognition that's not better accounted for by pre-existing established or evolving dementia, has a short onset, and then an indication, in the exam, in the history, in the lab findings that indicate that this is caused by a direct physiologic consequence of a medical condition or an intoxicating substance or medication or some other cause. So again, just to reiterate the features of delirium, the rapid onset, short duration, mood shifts from lethargy to agitation. Patients with dementia are at an increased risk for delirium, and it usually, but not always, resolves with treatment. It is usually reversible by treating the underlying condition. But if it's unrecognized, then the underlying condition goes untreated, and it can be potentially fatal. Things like infections and toxicity and malnutrition, things like that. So these are just some of those, again, just to reiterate those striking characteristics, that the disorientation, the loss of self-awareness, attention and concentration, that slow and muddled thinking. There may be hallucinations and delusions present, often incoherent speech, an increase or decrease in metabolic activity, and again, they're easily distracted. There are several studies that have shown that delirium is frequently unrecognized by ICU clinicians. Somewhere between 66 and 84% of patients with delirium go undetected. And instead, these mental status changes are often attributed to dementia, delirium, even psychosis, or thought to be just an expected occurrence among the critically ill. And there's some reasons for this diagnostic inaccuracy, and those largely include a lack of information about the prevalence of delirium, and also a lack of a structured interview format that's used, kind of widely in healthcare for delirium. The assessment to orientation, or the assessment of orientation to person, place, time, and situation is really insufficient for this case. Another is just flat-out subjective decision-making, and then another is when, again, the clinician has limited awareness of the existence of any pre-existing cognitive deficits and the prevalence of dementia. So, frequent cognitive assessments daily, a formal assessment on the hallmarks of delirium, that attention span and fluctuation, those kinds of things really make diagnosing the condition more difficult, the lack of those. The physicians depend on health records or nursing notes to identify a fluctuating course, and so, it's kind of key that regular health care assessments be done for delirium in the healthcare setting, or in the acute care setting anyway. Which would then allow a physician to see what's happening. So it can be delayed by infrequent observation or documentation, but it can be improved by, again, recognizing the high prevalence of delirium, monitoring for the signs, and then using standardized measures. And there is a standardized measure that has been around for a while. I know psychologists use it a lot when they're assessing for delirium, and it's called the Confusion Assessment Method, or CAM, and then there's a CAM-ICU, that's used, of course, in the ICU, that takes into account some of the setting differences. And then there's also a scale that I know a little bit less about, but one called the Delirium Rating Scale Revised, which is the DRSR-98, not to be confused with the Dementia Rating Scale, but the Delirium Rating Scale. The CAM is really considered to be the most useful instrument because of its accuracy, the brevity, and ease of use by clinicians and even lay interviewers. And it asks, it looks at things like, it doesn't ask anything of the patient. It looks at things like, was there an acute onset? Did the patient have difficulty focusing attention? Are they easily distractible or having difficulty keeping track of what was said? Did this behavior fluctuate during the interview, tend to come and go or increase and decrease in severity? It's things like that. So it's observational and then very easy to score and, make some determination about. Possible contributors to delirium. Just put a list of a few of them here. So, alcohol, medications, pain, infection, toxic, and metabolic disturbance. And as I mentioned, it's pretty common after surgery in older adults. So it's really useful to review the patient's history with regard to recent onset of illness and chronic illnesses, as well as their medication history. And also, it's possible that several of these causes are found to contribute to a delirium in any given case. So it would be considered multifactorial in origin. So although the symptoms of delirium and dementia can overlap considerably, there are a number of clues to differentiate, most of which I've listed. And they're here on this slide, many of them. In particular, again, you should investigate the timeline of events, the patient's functional status, and comorbid conditions. And note here that clouding of consciousness refers to a patient's ability to perform higher cognitive functions, not really to a patient's state of wakefulness. With dementia, there's more of a gradual deterioration of abilities. It's progressive, it's non-reversible. Mood may be depressed in early dementia, and although treatment may slow the progression, dementia doesn't resolve. So we're gonna look more closely at dementia now, but just seeing those side by side. I have another chart later on that lays delirium, dementia, and depression side by side. So here's an NIA definition of dementia: the loss of cognitive functioning, thinking, remembering, and reasoning, and behavioral abilities to such an extent that it interferes with a person's daily life and activities. So I mentioned earlier that dementia can affect memory, language, problem solving, concentration, visual perception, personality, emotions, and mental health and motor skills. Dementia is still used as an umbrella term assigned to a number of neurocognitive disorders that represent the progressive deterioration of global and cognitive functioning. So it's defined as a state of impaired memory with a loss of other cognitive abilities or change in personality that is persistent, so greater than 6 to 12 months, and interferes with previous cognitive and or social functioning. That's really key in the diagnosis. It's interesting to note that most people with dementia do not complain of memory loss. But the essential features of dementia are impairment in short and long-term memory associated with impairment in abstract thinking, impaired judgment, other disturbances of higher cortical functioning, and then even personality change in some types of dementia. But dementia is not diagnosed unless the impairment is severe enough to interfere significantly with work or usual social activities or relationships with others. So the types of dementias, you've probably heard of most of these, at least the top several. Alzheimer's, vascular, Parkinson's disease dementia, Lewy body dementia, frontotemporal dementia. We're going to go through some of these. About 50% of dementias have a mixed component, so there's more than one thing going on, more than one etiology. Alzheimer's is responsible for about 60 to 80% of all dementias, 5 to 8 million people in the U.S. And here, of course, memory loss is the most common early symptom. About 10 to 15% are vascular in nature or have a vascular component. 10 to 15% are vascular dementia only. About 40% of all dementias have a vascular component. And, of course, that is when there's involvement with strokes or other cerebral vascular damage. So dementia always has an underlying organic cause, and the course of the dementia depends on the underlying cause. So it may be progressive, it may be remitting, or it may be static. Dementias that are due to brain tumors or subdural hematomas and metabolic factors have a gradual inset. Dementia due to Alzheimer's disease usually involves a slow deterioration over many years that continues until death, etc. So let's look at some of those separately. Well, first, just a chart showing the proportional range of dementia subtypes. And then, patients with dementia really struggle with memory, although, as I said, they don't always come in and identify that they have memory problems. They have executive functioning problems, self-care tasks related to toileting, bathing, grooming, and taking medications accurately, and personal safety challenges, things like driving and wandering and falls. Those are all areas of difficulty or increasing difficulty in dementia. Patients with dementia can also show signs and symptoms of depression, as I've mentioned, and they, as I've also mentioned, experience a higher incidence of delirium. Because of the potentially co-occurring states of dementia, depression, and delirium, it's really often difficult to determine what the patient is presenting with during an assessment. But they don't always come in with very clear impairments. Sometimes people present with really good verbal skills and they're living independently, and you should never let that preclude the evaluation of cognition in an older adult, especially if there are any subjective complaints. So Alzheimer's. Alzheimer's is an irreversible, progressive brain disorder that slowly destroys memory and thinking skills and eventually the ability to carry out even the simplest tasks. Most people have what's considered to be late onset, so symptoms first appear in their mid-60s. Early onset Alzheimer's occurs between a person's 30s and the mid-60s, and it's rarer. Again, Alzheimer's is the most common cause of dementia among older adults. It was described first by Alois Alzheimer in 1906. You can see that it usually begins with difficulty remembering recent events and learning new material, and there's some, often some corresponding irritability that goes along with that on the part of the patient. And as it progresses, these problems intensify. Frequent features. Again, I mentioned depression frequently occurs early in the disorder when the patient first becomes aware of their decreasing function, but as the disorder progresses, insight becomes impaired such that the patient's no longer aware of their deficits, and depression is a lot less likely to occur, which is a little bit of a mixed blessing, but a pretty observable phenomenon. Immediate and brief catastrophic reactions may occur in reaction to negative events at this later stage. So a person may seem to be reacting appropriately when something happens, but their reactions tend to not persist. Again, memory problems are typically one of the first signs of Alzheimer's, although really the initial signs can vary from person to person. A decline in other aspects of thinking, like finding the right words and vision, spatial issues, and impaired reasoning or judgment can also signal the early stages of Alzheimer's. And it's, people with Alzheimer's have trouble doing everyday things, and they ask the same questions over and over. They may get lost easily. They may lose things or put them in odd places or find even simple things confusing. And sometimes as the disease progresses, some people become worried or angry or violent. Others are just, sweet and conversational. They confabulate without knowing that that's what they're doing, but that's exactly, what comes across is just a lot of words and making up of answers that sound normal. To the untrained clinician and to a lot of other people. They think that because a person is conversant and social that they're doing just fine, and again, that's not always the case. Vascular disease or vascular dementia, here just the criteria that I'm showing you for major or mild, or the description from the DSM-5 of major or mild vascular neurocognitive disorder. Vascular dementia is the second most common cause of dementia in elders. Vascular disorder is the second most common cause of dementia in elders. Vascular dementia refers to the progressive loss of memory and other cognitive functions that are caused by vascular injury or disease within the brain. So sometimes the symptoms may be difficult to distinguish from Alzheimer's. Problems with organization, attention, slowed thinking, and problem solving are all more prominent in vascular diseases, while memory loss is more prominent in Alzheimer's. So, and again, it's not always, it doesn't always present that black and white, but that is a good generalization. Vascular cognitive impairment involves changes with language and attention and the ability to think and reason and remember that are noticeable but not always significant enough to greatly impact daily life when it's just at the the milder before it really progresses to a more severe stage. But because these changes are caused by vascular injury or disease within the brain, they will progress slowly over time. These are some of the risk factors of vascular dementia. You see that they are cardiovascular in nature or caused or contributed to by habits and behaviors that affect our vascular system. They may be minor and undetected for a while, but there is cumulative damage. About a quarter to a third of people who have a stroke will develop dementia. And, as I think I said, vascular dementia often co-occurs with Alzheimer's disease. And it may be misdiagnosed as Alzheimer's disease. Actually, that is a pretty frequently occurring thing. people that kind of cursorily diagnose Alzheimer's disease without a thorough evaluation and a really deep look at the domains that are impacted and how they're impacted, and the onset course, and the neuropsych testing that is really effective and helpful in looking at the etiology of these types of dementias. So when that's not done, you see a lot of misdiagnosed vascular dementia as Alzheimer's. So again, the risk factors: diabetes, high blood pressure, heart disease, smoking, high cholesterol. The symptoms really depend on the location of damage in the brain. So, maybe organization or attention or slowed thinking or language or memory. Symptoms may be sudden or gradual. It may progress more slowly than Alzheimer's disease, and it also may affect strength and balance. And in subcortical dementias, depression tends to be a part of the total symptom package, with mood alteration not just situational, but more likely to be persistent. But it may respond to standard intervention. But it's also true that depression is likely to exacerbate cognitive deficits. Depression is very common after a stroke. So often in vascular dementia, there's kind of a patchy presentation of the deficits with insight preserved for a time so that the person is aware of their impairment. So again, depression may be a result as a reaction to these limitations. But here also, depression is likely to exacerbate cognitive deficits. So Parkinson's disease dementia is a decline in thinking and reasoning that develops in many people who are living with Parkinson's at least a year after the diagnosis. So it's not an onset at the same time as the onset of symptoms of Parkinson's. It is the brain changes that are caused by Parkinson's disease. They begin in a region that plays a key role in movement, but they lead to those early symptoms that include tremors and shakiness and muscle stiffness and a shuffling step and that stooped posture, that difficulty initiating movement and the kind of masked facial expression or lack of facial expression. But as those brain changes gradually spread, they often begin to affect mental functions, including memory and the ability to pay attention, make sound judgments, and plan the steps needed to complete a task. They're little, small changes. They're abnormal microscopic deposits composed of alpha-synuclein, which is a protein that's in the brain, found in the brain with a normal function that we don't really know much about yet. These deposits are called Lewy bodies after Frederick Lewy, who is a neurologist who discovered them while working with Dr. Alzheimer's lab in the early 1900s. So Lewy bodies are found in several brain disorders, including Lewy body dementia and Parkinson's disease dementia. And the evidence suggests that Lewy body dementia and Parkinson's disease dementia are linked or may be linked to the same underlying abnormalities in the brain that process this alpha-synuclein. On to Lewy body disease. It's a multi-system neurodegenerative disorder that affects cognition, behavior, and mood, movement, sleep, and the autonomic nervous system. So Lewy body dementia is a type of progressive dementia that leads to a decline in thinking, reasoning, and independent functioning because of those abnormal microscopic deposits that damage the brain cells over time that I just mentioned. It was newly described in the literature in the 80s, and diagnostic criteria was established in the 90s. So Lewy body dementia is a dementia syndrome, again associated with those Lewy bodies in the brain. But it's an umbrella syndrome under which falls dementia with Lewy bodies and then also the Parkinson's disease dementia. And it's the most misdiagnosed form of dementia. It's often diagnosed as Alzheimer's or Parkinson's or even a psychiatric disorder. So let's see. It's really difficult to diagnose. The presenting symptoms vary, and so it typically does require a specialist or the working together of the neuropsychologist and the neurologist. There may be a delirium that presents prior to the dementia. It's also a challenge to treat. It has some co-occurring severe medication sensitivities, and so the treatments that are prescribed are often off-label. Also, the public doesn't know a lot about Lewy body disease. They often hear about it first at the time of diagnosis, and so the caregivers have that kind of added stress of becoming educators and advocates. And the medication sensitivities of Lewy body disease are often unfamiliar to a lot of healthcare providers, especially in the emergency room. So if you ever go to the ER with behavioral concerns around Lewy body dementia, you may want to request a neurology consult in addition to the ER doc. So frontotemporal dementia, This is also an umbrella term for a group of kind of uncommon disorders that primarily affect the frontal and temporal lobes of the brain. And frontotemporal dementia has an insidious onset and a gradual progression, but it can present with either a behavioral variant or a language variant. The behavioral variant would include impaired social cognition and or executive abilities with behavioral symptoms such as disinhibition, apathy, lack of empathy, compulsive behavior, and hyperorality. The language variant presents with a loss of word memory, including speech production, word finding, and comprehension and grammar. But it's possible that a person may present with both types. This is often mistaken for depression, bipolar disorder, or even schizophrenia. And interestingly here, performance on brief cognitive screens often appear normal with frontotemporal dementia. So begs the necessity of a more thorough evaluation. So just some of the other dementias that are associated with infectious disease. I'm not going to talk about these, but you see them. The features are similar. Cognitive functioning impairment, some depression, emotional lability, motor skills impairments. Here are some that are associated with metabolic disturbances like low B12, hypothyroidism, infection, as I mentioned, and then remember those that are caused by brain trauma, of course, concussion, contusion, subdural hematoma, normal pressure hydrocephalus. So let's look at the difference between dementias. We're not going to walk through how to diagnose each of these or how to tell the difference between each of these. You've heard me talk about some of the differences, and formal neuropsych testing will bear out patterns that will align to many of those differences. But the way it's diagnosed is really by looking at the differences between the dementias. So it's onset, the early symptoms, the progression, the co-occurring conditions. Were the early symptoms, were they cognitive, motor, behavioral? The progression, what speed has that been? The symptoms, what age of onset? Older or younger, as we talked about earlier. And then the co-occurring conditions, of course, if there's a cardiovascular component, then you at least think of vascular dementia as you go about your evaluation. Some of the challenges, though, are when there is a delayed diagnosis or a misdiagnosis, locating knowledgeable medical professionals, a lack of general information, and then the isolation of many older adults. So just looking at dementia versus those age-related changes, again, damage to the frontal lobes or the cells that send information to the frontal lobes often results in declining function. And research has shown some decrease in executive function as people age. So that decline, some decline in the ability to adapt to new situations is not abnormal. But a slowing of the ability, to shift set for verbal information, a reduction in the ability to successfully divide information, and the ability for complex problem solving, and then some decline in inhibition is normal as a function of aging. But remember that that's a decline in, not the loss of these abilities. So looking at this chart, you can see some typical age-related changes as compared to signs of what we would consider impairment or even dementia. And as I mentioned earlier, because of the potentially co-occurring states of dementia, depression, and delirium, it's often difficult to determine what the patient is presenting with during an assessment. So you should really note, as I mentioned a few slides ago, the onset, the patient's level of symptoms, of course, the appearance of fluctuating, whether there are fluctuating symptoms. But you definitely want to inquire about and obtain a good history and use collateral sources. You want to rule out delirium and reversible causes. You want to obtain the labs that will help you do that, or have those obtained by the medical providers, of course. And then cognitive screening, if that bears any indication that a more thorough evaluation should be conducted, if there's any indication of impairment or it's a more complex case, you want to refer for a neuropsych eval or conduct a neuropsych eval if that's your role. And then neuroimaging is often indicated if there is a rapid decline or an unexplained or any unexplained focal neurological symptoms. So that's just kind of the course of working up dementia, not the actual session. We'll show that in just a second, or kind of an overview of that. These are from the Mayo Clinic, just, the domains that with the tasks that are laid out next to the domains that are assessed in evaluating for dementia. So So you see here that, for example, in complex attention, where there is impairment, major impairment with multiple stimuli. Sorry, let me string my words together better. Somebody whose attention is significantly diminished and has difficulty with multiple stimuli that's going to be more in the major category. Somebody who just takes longer with something will fall in the milder category. And you can see that kind of all the way down that chart. All right, let's look at depression. What time is it? Okay. Depression is a type of mood disorder. It's the most prevalent mental health problem among older adults. It is associated with significant distress and suffering, can lead to impairments in physical, mental, and social functioning. And of course, I mentioned early on, the presence of depressive disorders often adversely affects the course and complicates the treatment of any other chronic disease. Older adults with depression visit the doctor in the ER more often. They use more medication. They incur higher outpatient charges, and they stay longer in the hospital. Although the rate of older adults with depressive symptoms does tend to increase with age, depression either is not a normal part of growing older. In about 80% of cases, it's a treatable condition, but they are, as I mentioned, widely under-recognized and often are untreated or undertreated among older adults. Patients who are depressed usually have difficulty performing day-to-day activities due to a loss of interest and persistent feelings of sadness, which is a little different than the changes in functional ability with frank dementia or delirium. In severe cases, patients often express a lack of motivation, and they may even feel that life is not worth living. They may socially withdraw, curtail their normal activities, lose or gain weight, experience anxiety, and have difficulty with sleep disturbance. Depression in an older person with dementia should be considered if there are sudden changes, like any of these that you see here that are sudden, and the changes can't be explained by the development of a new physical illness or discomfort or delirium. Depression can cause a level of intellectual impairment that can appear to be dementia, but if it is depression, then the impairment reverses upon successful treatment of the depression. So, as I mentioned, it's difficult. It may be more difficult to recognize depression in older adults because one of the reasons is because the symptoms are often incorrectly attributed simply to aging. And as with some children, older adults sometimes will report somatic symptoms rather than a depressed mood. So that's needs to be part of the assessment. And of course, coexisting physical conditions and medications complicate the diagnosis. And again, coexisting dementia may complicate it. And if depression is suspected, all the relevant symptoms need to be considered related to depression and then treated, and then you see what's left after that. And then, as I mentioned, often people have both depression and dementia. 20 to 40% of cognitively impaired elderly persons exhibit depression or depressive symptoms, and people with dementia are more susceptible to the adverse effects of anticholinergic medications. So again, some of the difficulties in differentiating between depression and dementia, it's the imprecise use of the term dementia often that confuses discussions of patients and conceptualizations of the disorders, because people really do use that word freely. When somebody just has cognitive changes, often somebody will say, yeah, they've got dementia or they're demented without a formal diagnosis, and that is not only unfair, it is dangerous. Even as you see here, that intellectual functioning decline in normal aging that we've talked about is sometimes mistaken for dementia. In the early stages, when symptoms are relatively mild, the differentiation from the memory changes associated with normal aging can be difficult, again, because the intellectual functioning decline in normal aging is sometimes mistaken for dementia. But elderly depressed patients don't really report those common symptoms of depression associated with younger adults, but they may only complain of, as I mentioned, somatic problems or of memory problems. And with older depressed patients, other people tend to just focus on the memory problems. But if the depression is treated and it was just a depression, the memory problems are likely to resolve. If the focus is only on the memory problems, the patient is likely to be misdiagnosed as having a progressive dementing illness when that problem really is depression. So this kind of assessment error can really have a profound impact on the life of somebody so diagnosed. right, as I mentioned, this is a 2-page chart that you will be able to see better in your handout that shows you the features, so onset, acuity, course, duration, consciousness, hallucinations, delusions, attention, concentration, laid out looking at delirium, dementia, and depression. So that's page 1. Page 2 has orientation, memory, psychomotor, speed, thinking, physical illness or drug toxicity, affect, and sleep-wake cycle. And I obtained this from the Winnipeg Regional Health Authority website. Sorry, I didn't have room to put a resource on there, reference on there. But it's the Winnipeg Regional Health Authority. And I thought it was a really neat chart because it does give you, going backwards now, just the things that I've talked about. So the onset of delirium is acute. Dementia, it's insidious. Depression, it's variable. You can look at those kind of side by side. Those are largely generalizations because everybody is, an individual person. And again, these may way overlap, but for example, the acute onset of delirium is an absolute. It just doesn't always appear that way if it's mixed with something else. All right, so why would we do a cognitive evaluation? Well, I think I've made that kind of clear through this, that identification can lead to appropriate intervention, helps you to rule out reversible causes of what's going on. All of them have treatments, and the evaluation will inform the treatment and the supervision and placement planning if that's necessary. You're looking for whether there is impairment and what level of impairment, mild, moderate, or severe. And then, has there been clinical change? What is the nature of that change? What cognitive or behavioral domains are impacted? And then what are the possible causes? The etiology can include diseases or conditions. So the evaluation process itself is a lengthy one when you're doing a thorough evaluation with an older adult. And it includes an interview, which includes current mental status, the event precipitating the request for the eval, the patient's perception of the problems, prior psychiatric history, social aspects of the patient's situation, and then the history, which can really be the most important part of an evaluation of this kind. And this would include information gathered from the patient when possible, from collateral sources like medical records, if possible, but also from family and other people who have knowledge of a patient. Often a patient who has cognitive impairment is not a good historian. They may flat out tell you they've got 6 grandkids and sound just absolutely certain and make you believe them, and they may have 2 or none or 12, or they may not have any idea. But that may be what they think. They think they have 6. The point there is, though, that they just are not always a good historian. It's better to have somebody with them when taking a history, or somebody helping to check that with your records. You also want a description of behaviors, the cognitive and memory functioning, and problems, and their effect on activities of daily living and instrumental activities of daily living. You want to get information about the onset time, the course of the illness, the problems. This is where you need to learn if the symptoms have been chronic or progressive, like Alzheimer's and other neurodegenerative diseases. If they've progressed in a stepwise manner, which you would see maybe in vascular dementia, or if it's a slow and steady decline or been relatively static. So then again, out of the medical records, you want medical history that's not obtained from the patient or collateral, like medications, the serum and urine analysis, alcohol, specific drug levels, any imaging, CT, MRI, or PET scans that are available. You're looking for treatable causes. Again, vascular disease has cardiovascular risk factors such as smoking and hypertension and diabetes and cholesterol. Normal pressure hydrocephalus shows up as a wobbly gait and a wacky presentation, so the dementia, and an incontinence. It's called wet, wacky, and wobbly. So you see those things in the medical records and in the history and in the collateral information you gather. Metabolic disorders, medication problems, sleep apnea, behavioral reports, both behavioral compliance and or changes. During the interview and the history taking, you also will be observing for things like the ability to learn and retain new information, handle complex tasks, gait, vision, and hearing. You're assessing their orientation, their alertness and awareness of time, person, place, and situation, their communication, so the ability to speak, understand, and respond appropriately, speech patterns, their judgment, their insight into the self and their situation, and their ability to direct decision-making, their appearance and behavior, their attire and their grooming and their appearance, their general level of intelligence, the level of education, fund of knowledge, mood, reactions to the topic being discussed, the general perspective about the situation. Are they sad or angry about the problems they're bringing in? Their visual spatial ability, are they paying attention to visual cues? Do they attend to both right and left sides of their bodies? Are they aware of their cognitive changes or unusual behaviors? What is their memory for their personal history? And then you want to screen their mental status, formally screen their mental status to help detect the presence of general cognitive dysfunction and focal problems, looking at, like orientation, registration, attention, calculation, recall, language. And then, of course, the formal assessment is the next part of the evaluation process, and that's where testing is performed in a structured and controlled environment. The patient is seen alone. You're using standardized assessment instruments, and test results are compared with scores from other patients the same age and education level. And again, I mentioned it's the overall pattern of test findings here rather than a particular test score that's important when you're interpreting results in this kind of evaluation. The overall pattern would show an ability or set of abilities that are below expectation or impaired. That pattern is really helpful in diagnosing specific disorders and in suggesting compensatory strategies that might be helpful. So neuropsych tests tap multiple domains because neuropsych function depends on neural systems rather than focal brain regions. So this, again, that pattern of test findings rather than one test score is important when you're interpreting. So I'm not going to define all these for you. It is 11:47. I want to keep moving. But attention, including selective attention, focused attention, divided attention, and sustained attention, these are all areas that you want to evaluate. Executive functioning, language, perceptual motor function, learning and memory, and social cognition. And then, of course, affect and psychological functioning. As with any evaluation, you want to look at motivation and secondary gain and the contribution of any other diagnoses the person may have. And the affect, of course, this is where you're going to evaluate for depression, both by using the information that you gathered during the interview and the use of the questionnaires or standardized instruments to assess the presence of depressive symptoms. Historically, there's been a relative dearth of normative data for older adults, but there are a number of measures now that have normative data through approximately age 90. It's really important that the tests are appropriate for the age of the person you're evaluating. They also need to be valid and reliable. They need to, the standardization sample needs to be representative of the person that you are evaluating, and the tests need to either be developed specifically for older adults or, again, have norms that include the age that you're evaluating. Some of the other things that you want to consider are, of course, the time it takes to administer the different assessment instruments, the skill that's required, the ease of administration, whether or not the instruments are appropriate for the particular culture, language, and education level of the patient that you're evaluating, their clinical utility, whether they are created for clinical utility versus research, and then whether or not the STEM materials will be appropriate also for the impairments that you're maybe working with. Ideal screening instruments are those that can be administered by clinicians at all levels and require 5 to 15 minutes to administer to most patients, including areas of orientation and attention and concentration. And so this is what we do in the screening, is to do the briefer area. We evaluate more briefly these areas of orientation and attention and concentration, executive functioning, language, spatial ability, memory, because we have to be practical about what's possible in a particular setting in the patient population. So often we will not evaluate further with neuropsych testing if there's not any indication of impairment, but remember that sometimes people can look good on the testing, so you need to also consider the history, the reason for the referral, and everything else you've learned in your evaluation to determine whether or not to move forward with a longer evaluation. But just some of the instruments used in a brief screen. There's brief cognition assessments. The brief cognitive status exam helps evaluate global cognitive functioning in patients with dementia, mild MR, TBI, or suspected Alzheimer's disease. Some of you may be familiar with this. It is a standalone version of the BCSC that's found in the WIMS-R, the Wechsler Memory Scale, and it covers 7 cognitive domains: orientation, time, mental control, planning and visual perceptual processing, incidental recall, inhibitory control, and verbal productivity. Some of these others you may be familiar with just from being around the healthcare setting. Minicog, it's a 5-point cognitive screen that includes a 3-word verbal recall and a clock draw. The Mini-Mental, which is one of the most widely used cognitive assessment tools. A lot of people have issues with that one, myself included. The MoCA, the Montreal Cognitive Assessment, was developed at the Montreal Neurological Institute. It's a pretty sensitive cognitive screen, takes 12 to 15 minutes. And then the SLUMS, the St. Louis University Mental Status Exam, was one of the first cognitive assessment tools to address mild cognitive impairment. The Kochman test was developed at the Mayo Clinic. And then the AD8 is just an 8-item questionnaire. And it's administered to an informant, such as a caregiver, rather than the patient. If the results of any of those are abnormal, or for another reason you determine that you want to do a more deep evaluation, the RBANS update is a brief individually administered battery to measure cognitive decline or improvement, and the domains here are immediate memory, visual, spatial, visual constructional, language, attention, and delayed memory. So looking at memory next. The Wechsler Memory Scale, which is the most widely used scale of adult memory. The RAML-2 and the RAML-3 is currently in development. Should be out sometime in 2020, late 2020. RAML-2 is a broad-based memory battery that provides a flexible measure of memory functioning and learning. The Rivermead Behavioral Memory Test, 3rd edition, is an internationally renowned, highly sensitive ecological test of gross memory impairment. You're probably familiar with the Ray Auditory Verbal Learning Test. It evaluates verbal learning and memory. The CVLT, the California Verbal Learning Test, 3rd edition. It's the most comprehensive assessment of verbal learning and memory for older adolescents and adults. And then language. The Boston Naming Test measures confrontational word retrieval. The Peabody Picture Vocabulary Test, 5th edition, published last December, is a norm-referenced and individually administered measure of receptive vocabulary based on words in standard American English. And the Expressive Vocabulary Test, 3rd edition, also published last December, is a norm-referenced and individually administered test of expressive vocabulary and word retrieval. And then the COWAT is the Controlled Oral Word Association Test, is a verbal fluency test that measures spontaneous production of words that belong to the same category or beginning with some designated letter. Moving on to executive functioning. The DKEFS, the Dallas Kaplan Executive Functioning System, provides an evaluation of those higher-level cognitive functions. The BADS, the Behavioral Assessment of Dysexecutive Syndrome, helps to predict everyday problems associated with a dysexecutive syndrome. That includes disorders of planning and organization and problem solving and setting priorities and attention. It's one of the major areas of cognitive deficit that can impede functional recovery and the ability to respond to rehab programs. So the BADS specifically assesses those skills and demands of everyday life. The executive interview, or Exit 25, that's a screening instrument for executive cognitive dysfunction in patients with mild dementia. For general cognition, you're familiar with the Weiss and the Woodcock and the Stanford-Binet and the NAB, but I also want to mention the Test of Premorbid Functioning, which estimates an individual's premorbid cognitive and memory functioning. It's a revised and updated version of the WETAR, the Wechsler Test of Adult Reading. We call it the TOP, the Test of Premorbid Functioning. It helps predict pre-injury IQ and memory abilities. And then for social cognition, ACS Social Cognition Test, which is from the WASWIMS Advanced Clinical Solutions. It's now a standalone test, and it includes 3 subtests: social perception, faces, and names. And it's designed to measure relevant components of social cognition. Functional ability, the Texas Functional Living Scale, TIFLS, provides an ecologically valid performance-based screening tool to help identify the level of care an individual requires. The Independent Living Skills, ILS, is an individually administered assessment of the degree to which adults are capable of caring for themselves and their property. And then mood. Most of you are probably familiar with the Beck Depression Inventory. The BDI Fast Screen for medical patients is a version of the BDI-2 that's designed specifically for medical patients. And then, of course, the BAI. And then here's one I meant to mention earlier that I didn't mention, and it is the Cornell Scale for Depression in Dementia, and it helps look at a person who has dementia, whether or not some of their symptoms indicate an overlying depression that also needs to be treated. And it looks at it has unable to evaluate absent, mild, or intermittent severe rating system, and then it evaluates the domains of mood-related signs, behavioral disturbance, physical signs, cyclic functions, and ideational disturbance. And so it's really helpful when you're working with somebody that you think may be depressed and has dementia. And then the quality of life inventory is just one that people often like to add for patients who still have, who are able to think about their own life, to participate in an assessment of their well-being and satisfaction with life. It's helpful in planning. So generally, dementia refers to an acquired impairment of multiple neurocognitive domains, and the use of this term is sometimes restricted to progressive syndromes in the elderly, the most common of which are AD and vascular disease, as I mentioned. But there's others that produce dementia later in life that include Parkinson's and Pick's disease and Huntington's disease, and a variety of metabolic and infectious disorder. So when you're evaluating patients who are suspected of having dementing disorders, you typically need to try to answer these questions. Is there evidence for some type of acquired impairment? What is the nature of the deficits? And then if deficits have been detected, 2 additional questions. What is the likely associated disease process, and what interventions are appropriate? It's a helpful way of framing that because, when you're treatment planning, you're considering the referrals that you may need to make. You're considering whether or not the person needs day-to-day assistance and what kind of assistance, what environment they need to be in, what their communication ability is and what that means for the caregivers that are working with them and their family, what level of supervision they need, what medications they may benefit from, or whether or not those need to be monitored and or supervised completely, and other changes and recommendations, as you might suspect. I have just 2 more slides to show you, and this is a website, Gero Central. You can see the URL is gerocentral.org, and this is a place where there are many educational materials and training opportunities for psychologists and trainees that are related to working with older adults. It's an internet clearinghouse website that brings together geropsychology training and professional development resources to really help increase the ease of access. So there's a clinician toolbox there, some research resources, Pikes Peak geropsychology competencies, etc. And I just want to make sure that y'all are aware of it if you have an interest in this field. And then also the APA Office on Aging, and then places like aging.gov, the National Institute of Aging, other places like that have a lot of good resources as well. It is 11:59. I want to thank you very much for attending. Please send me your questions since I went straight up till noon. I'm going to switch slides to another slide that still has my email but also has our customer support numbers and email address, customer support website. But please send me your questions, and we'll get an email back to you. Thank you all for being here.